afternoon to everyone, and thank you very much, Professor Samat and the Council, Professor Ishan, for asking me to do this talk on personalized medicine, what's in store for the future, and what is being currently used. So I know that Prof. Ishan was a bit concerned earlier today, where he was asking, is it personalized medicine or precision medicine that I'm talking? For a practicing clinician, we should not get too sort of hit up with those words. I mean, it's basically the same. The newer term is precision medicine, but personalized medicine is another absolutely perfect term to be used. So if the summary of my talk is, I'll talk about some basics to put you into the context. The people listening to this, I'll talk to you about personalized and precision medicine, tell you what that is, and take some examples from classical genetic diseases, allergy or asthma, immune deficient diabetes, and cancer, and focusing on cancer because that is where precision or personalized medicine has been most developed, and we're using it on a day-to-day basis, and lots of advancements will come up in the near future. So if we look at the basics initially, we know that the immune system plays a vital role in prevention and control of cancers. This is schematic of the immune system, where if the normal parts of the immune system are not working, you get immune deficiency. If there is dysregulated immunity, you get autoimmunity and allergy. And if certain cells cannot be got rid of, the malignant cells, you get a cancer. The cells of the immune system work together, the B cell, the T cell, and the antigen-presenting cell. They have to talk to each other. That is so important, getting a good immune response. Once the immune response gets underway, it has to be brought back to baseline because otherwise it can go out of control. And two breaks of the immune system are CTLA4 and PD1L pathway. And these are the breaks. You do need a break of any physiological system. Now, the cancers are beautiful in this because what they do is they would hide the cancer from the immune system. And that is where immunotherapy comes into play and where we have to consider immunotherapy in certain cancers. So that is the sort of basis of knowing that pathway with regards to cancer immunotherapy. We know that in many cells, you have a signal that backs on a receptor that goes to the nucleus and then the effector occurs. Now, what is the importance of knowing these pathways in the cancer cell and in a normal cell? The importance is by knowing the pathways, we can intervene specifically in the cancer cell, in the disease cell, without affecting normal cell. That's what we want to do to protect the normal cell while we attack the disease cell or the cancer cell. So the central dogma of molecular biology is DNA, RNA, and protein, with transcription and translation being given to the processes that are involved. So protein is the ultimate process thing that gets the function of function in place, and DNA codes for that. And we know that if there are changes in the DNA, you have different letters of the DNA code. If there are changes, that can lead to a disease state. Certain diseases are very severe, certain diseases are less severe, and there are hotspots in the genome that can be affected by these different changes. The Human Genome Project, which started many years ago and was completed, was a big breakthrough. It was advanced, it was made faster by the new technologies, etc. And we got the draft sequence and then a more definitive sequence, and these were sort of publications at the beginning of the century. Why was this possible? But that was because of the rapid advances in sequencing technology and the reduction in cost. You can see the number of sequences that were done up to that year, the cost of the sequencing in the red line, and then Moore's law is shown there with regards to computing technology, and that it was even faster than computing technology, the cost of computing technology, when you compare the cost of sequencing. So a rapid decrease in cost of sequencing, that's what we're doing in the clinic at the moment to be able to get precision and personalized medicine. Several technologies have been used, as shown in this figure. The different technologies, newer technologies are coming rapidly into focus on a continuous basis. And if we look at the three different methods that we're using at the moment, in personalized medicine is targeted gene panel sequencing, whole genome sequencing, and whole exome sequencing. I won't go into detail about this because I've spoken about this in detail on many occasions, and several people would have given this similar talk. But these are the three methods we use: targeted gene panels and whole genome and whole exome sequencing. But the big problem we have to remember is the data explosion, the big data problem, because all of these different technologies produce a massive amount of data. We have to have good bioinformatics, and that should be good working between people, the pathologists, the clinicians, and clinicians should know what data is being, how to understand the data that is coming back to them, because it's no purpose in all this big data being generated, all these reports being generated, if the next set of medical doctors do not know what it means. And that is why new curriculums, etc., have incorporated this, because this is currently being used in clinic, and it will be used increasingly in different parts of clinical medicine. It is in the clinic. It is not something that is only in the lab. It is come into day-to-day clinical practice. So what is personalized or precision medicine? I'll talk to you about, and what are its uses, what are the conditions that we use it for. So personalized healthcare helps us move towards providing the right patient, the right drug at the right dose at the right time. And those are the four important tenets that we try to reach in personalized medicine. Now, if you take a patient group, when you give them a drug, some of them can get adverse effects, some of them can have benefit. And what we are aiming to do is to give a drug that won't be toxic and it will be beneficial. That's where we select the patients and give the specific drug rather than giving everyone the same drug. This illustrates the number of people who fail with the different drugs, including showing oncology, asthma care, etc. And this is important to select the correct patients so that we would be targeting those patients appropriately and not wasting a lot of healthcare resources in treating people unnecessarily, plus getting them adverse effects for no reason at all. So what it means is traditional medicine, everyone was considered similar, but we know that each of us is different in different genetics, phenotype features, etc. And that is what personalized or precision medicine take into account. It's all about you. You use different technologies that are coming to the world to be able to select the correct treatment for that specific person. And that is what the concept of precision medicine, personal medicine, comes in, using genomic technologies and other information to provide data so that we can target treatment in a better way and improve outcomes. So I told you that, for a practicing clinician, just take it as the very similar thing. There are differences. These are the definitions given: personal medicine, precision medicine, current medical practice, etc. But we are not philosophers. We are clinicians. We are using technologies, using results to treat patients. We are not just in a sort of hall discussing things in abstract. So the important thing is to understand what are its current use and what can it do. So without precision medicine, all patients would receive the same drug. Some will benefit, some will not benefit, some will develop bad adverse effect, and it can be dangerous to the patient. With precision medicine, you use DNA technologies together with other processes like proteomics, metabolomics, transcriptomics, etc., where each patient will be given a specific drug for that patient that would benefit that patient, and therefore we are expecting benefit across the board. So current medicine, different sort of landscape where all patients are given the same drug, and you can see chemotherapy, radiotherapy, etc. You can see some benefiting, some really doing badly, while in future, what is targeted for increasing amount of condition to be able to select treatment so that you get more benefit in a greater number of patients. There are drawbacks, but this is what has been worked in with trials coming on board rapidly. So this is again a part in schematic, standard medicine, standard treatment. Some have 100% responses, some less responses, some have no responses, and that can be dangerous. While in personalized or precision medicine, you find you have different treatments given for different people and expecting bigger responses across the board in this group of patients. So personalized medicine, what is it used for at the current moment? For prevention, for diagnosis, for treatment. Can we detect patients early or persons early? They may not be even patients. Detect protein defects or gene defects so that they can undergo certain processes in a timely fashion so that you can prevent this condition developing or push it back as much as possible. So that is prevention process. Diagnosis, being able to diagnose the condition accurately using the best technologies available and in an accessible way to be able to target the treatment and treat the patient so that they would be responding more appropriately to the treatment. So in summary, it's for prevention, diagnosis, and treatment. Now I'll take some examples in these different fields to show you where personalized medicine or precision medicine is currently being used quite successfully. This is just a snapshot showing cancer and hematology right at the top, infectious disease, cardiology, neurology, the whole gamut of clinical medicine in this is using these different technologies to be able to personalize care in a better process. If we take classical genetic disease, there are several classical genetic diseases, but I will take an important example where it has come into the clinic in a big way, that is cystic fibrosis, not common in Sri Lanka, but a big issue in places in the West, where you have the CTFR gene that is mutated, and there are different mutations in this gene, a whole lot of mutation. Knowing these different mutations and identify it allows us to use certain drugs, ivacaftor, lumicaftor, etc., so that we can target the appropriate patients who receive this drug. You don't give every patient with cystic fibrosis this drug. You give patients with targeted specific mutation this drug because that will benefit them, and it is not effective to use this expensive drug in patients who don't have those appropriate mutations. That this is a developing field with increased mutations being found to be in the process, in the bag of responding, as opposed to other mutations that don't respond. So again, precision, targeted treatment, personalized treatment depend on the mutation profile. When it comes to a condition that is close to my heart, allergy and asthma, if you look at asthma, it's a very complex process that is occurring in the tissues, where this figure is just put not to confuse people, but to tell you the amount of inbuilt processes, IL-4, IL-5, IL-13, TSLP, IL-33, etc., all integrating to cause inflammation in the airway and responses to allergens and viruses, etc. Now, the important thing is everyone will present with a similar phenotype or three or four phenotype. And if you use these medications in the very severe disease, because you have to remember healthcare cost is on people who have severe disease, not the mild asthmatic. It's a person who is receiving large dose of steroid, ICU care, ITU care, etc., needing a lot of health resources. That is the group that we have to be able to treat them well so that we won't have morbidity and mortality, and also reduce healthcare costs. And knowing this group of patients, we don't want to give them expensive drugs without subcategorizing them, and that's where a personalized medicine comes into focus, because once we know the phenotype, you have the disease, you have different phenotype, eosinophilic asthma, neutrophilic asthma, then you endotype them. You go further using biomarkers and you endotype them and you treat them appropriately. Biologics, etc., you endotype them and treat them, and that's what we do in clinic currently with regards to a condition such as asthma. Next, you come to allergic disorder. We have a whole lot of molecular structures for the different allergens that have been worked out many years ago, and we use this in clinic. So knowing the proteins, the subgroup proteins that are causing allergens, the components protein, we are able to identify them using component resolved diagnostics and ISAC tests to be able to predict whether the person could get severe symptoms, whether the person would need different desensitization processes, whether it's going to be effective, etc. So again, prediction, diagnosis, treatment, selecting the correct treatment for the correct patient, which we are using in clinic in an allergy situation where we can Because we had the molecular knowledge, we can look at the protein and we have the components and we can use that in the correct context. Next, we come on to diabetes again, which people have been using it. Most patients have not a single gene defect. There are several contributing genes that are responsible. If you take the small group that has single gene defect, knowing the genetic cause of this condition again can indicate to you what treatment is best. Do you use low dose or high dose sulfonylurea? Do you use metformin? Or if it comes to the multifactorial group, that is the standard diabetic that we have, increasing studies are going on to be able to find biomarkers to indicate whether one treatment would be better than the other treatment. And this is a developing field, which we should get more data in the next 3 to 5 years with regards to a condition like diabetes. And in a condition like asthma and atopic dermatitis, you have far more knowledge to be used currently. So I've gone through classical genetic disease, allergy, and diabetes. Next, we go on to immune deficiency, a condition that I deal with in many patients. And I'll just take 2 examples here. If you look at immune deficiency, one of the gene defects that we were involved in finding was the CTLA4 mutation in patients with multiple autoimmune diseases and in patients who have immune deficiency. Now, previously, they would have only received immunoglobulin treatment, and they would have got bad lung complications, gastro complications, brain complications, etc. However, by finding this mutation, you can target them using a specific drug called abatacept, because abatacept used in this group of patients will reduce the complication. That again shows an important process of testing for these different mutations, finding it and treating them appropriately. Another example is a condition, gene mutation that we test for is the PI3 kinase gene gamma delta mutation, which again, if this is found in patient, they will respond to tyrosine kinase inhibitor. Now, tyrosine kinase inhibitors are used for treating cancer. So at the time that this was found, the question that was asked, can we use cancer drugs to treat immune deficiency? Now, if we did not know the molecular defect at that specific time, there was no way that you would think of using cancer drug, which can cause immune deficiency in treating a patient with immune deficiency. And that is a big advance in this group of patients, because using tyrosine kinase inhibitor, you can find that in addition to immunoglobulin replacement the patient have, you had an additional treatment, a personalized, precise treatment for that group of patients to improve morbidity and reduce mortality. Next, we come on to cancer, which again, I'll just spend a few minutes describing cancer, because personalized medicine or precision medicine is so important when it comes to cancer care. And because we know that the original treatment, surgery, chemotherapy, radiotherapy, they were effective in several patients, but there are several drawbacks. That is, if you give same chemotherapy for all patients, you can find that the problem occurring, some having adverse effects with no benefit at all. And you can see the different treatments that are being used, targeted treatment, antibody treatment, the cell signaling molecule blocking, etc. And as you go down the graph or the figure, you can see that the specificity or the precision with which the treatment is being used increases. So chemotherapy, it may be effective in one group of patients, while adding some other treatment, it would be beneficial if a specific gene defect is found. So personalized cancer therapy, what are we trying to do? We are trying to do molecular profiling to identify a group of patients, then add in prognostic markers, other predictive markers of drug adverse effects, etc., to be able to select the appropriate drug for the appropriate group of patients. So if you have a breast cancer patient, if you have an ovarian cancer patient, etc., we can categorize them so that the appropriate drug is chosen. So these are the technologies that they use: whole genome sequencing, pharmacogenomics, gene expression profiling, the identification of nucleotide polymorphisms to be able to optimize drug therapy and to reduce adverse effects so that we get a better personalized medicine approach to the patient to improve outcomes and improve the quality of life for the patient. So that is exactly what we're trying to do with this process in cancer patients. Very early on, in the last century, we had BCR-ABL gene fusion found in CML, chronic myeloid leukemia. Imatinib was given to that group of patients, and it transformed the management. Then we had HER2 positive breast cancer patient, because adding trastuzumab or pertuzumab or lapatinib to that group of patient improved outcomes. So those were again personalized. By doing some testing, you can improve, you can target specific treatments for that group of patients. So this is a quick run through some of the treatment options. We know we use TPMT. If you use a drug like azathioprine, before using drug like azathioprine, and then other colon cancer sort of markers to decide whether a certain treatment is being used or not. So if we take colon cancer, very common cancer, previously it was one treatment, some respond, some don't respond, some had adverse effects and may die of the treatment, etc. And that was not a good place to be. And now increasingly what is happening is you're substratifying the patients using different molecular markers, etc., to be able to give certain patients certain agents, while other patients will be given other agents. A good example is the EGFR mutation, the RAS pathway mutation, where if you have a certain RAS mutation, you would not use certain drugs because it's not going to be effective, or just wasting that drug and the patient, and you could harm that patient. Then you have the next one is lung cancer again, where we have with lung cancer, you have a range of mutation that we test for. And within those mutations, again, there are some changes that are more beneficial, some changes that are not good for specific drugs, and the adverse effect profile or the resistant profile can be determined by those changes. So three important cancers, breast cancer, lung cancer, and colon cancers, these technologies are being used at the present moment to be able to select the different medications. Two further slides, I will talk about important concepts that came with this process, that is called synthetic lethality. If you have two gene defects or more, the cell dies. If there's one gene defect, it increases cell viability. Good example is BRCA gene mutation in breast cancer and ovarian cancer. If you have only BRCA gene mutation, it increases viability and you get the cancer. And if you can, then it was found that there are two processes, two pathways, the BRCA gene pathway and the PARP gene pathway, that was found in 2005. And if you can create two defects, that is the BRCA gene is already mutated in the patient, and in those patients, if you use a drug like olaparib, then you can produce synthetic lethality. That is, there are two defects, and that this drug was approved in 2014 for BRCA mutant ovarian cancer. So you test the patient, it's BRCA mutant, and then you use a specific drug. So olaparib, you use it in patients with BRCA mutant ovarian cancer patient, rather than just giving to every patient and sort of wasting that drug. Here you use a targeted approach, and that is the example, that is the process of using the process of synthetic lethality. The next slide shows you the big studies that are ongoing currently, the MATCH study and the IMPACT study. The MATCH study is the molecular analysis for therapy choice. You analyze and you have about 25 to 30 different therapies depending on the analysis. Breast cancer, colon cancer, lung cancer, etc. The next study is the IMPACT study, which is again a big study where they're targeting the oncogenic drivers, DNA repair pathway, PI3 kinase pathway, RAS pathway, etc. They're targeting that, and based on that, they're assessing response. So these are two big studies that are reporting on a regular basis, and there's some great data that has come out from these studies in recent years and months. So personalized medicine, the goal is in a patient with metastatic disease. That's the group of patients who have a higher chance of dying and who standard therapy alone may not be sufficient. If they have a good signal, then you go for standard therapy. But if they have bad genomic signal or proteomic signal or transcriptomic signal, then you will think of combination therapy or other therapies which may be more targeted for those with poor prognosis, poor signature, genomic signatures that are true. And Is it in the world? Yes, it is, because way back in 2015, up to 35% of cancer therapies had a personalized element to it, where you had to do some biomarker testing before using this before using this drug. But these drugs are expensive, and you don't want to waste it, and you don't want to expose patients to unnecessary adverse effects, and you can predict if certain people will produce adverse effects or not with these different medications. So in this quick run through about personalized or precision medicine, as we would call it, I went through the basics and told you the important facets with regards to cancer care, and about analyzing genomics and other measures like transcriptomics and proteomics, the data load that we have and the importance of taking that into account, and clinicians, medics at all fields knowing some aspect of this, because it is coming into our process. It is important to know the possibilities and the limitations of this process, so at least the patients could be directed in the correct pathway to get the correct treatment. I told you what personalized or precision medicine was and what is our target with regards to prevention, diagnosis, and treatment, and monitoring treatment. Took some examples from classic genetic disease, cystic fibrosis, asthma, allergic disorders, where we're using component, diabetes, immune deficiency, we are finding a gene defect would allow us to use different treatments which we would have never thought we could use. And finally, with cancer, in a whole range of cancer, I've just taken a few cancers: breast, lung, and breast, colon, lung, and ovarian cancer. But there's a whole range of cancers that personalized or precision medicine is used at the current moment. So this is a way forward. People do need to know some aspects of this to be able to refer the patient appropriately to the correct pathway if they are not practicing it in a big way. But in all aspects, the personalized medicine is here, and it will be there for a long time in the future. Thank you.